Yes, yes, thank you so much, Michael. And that leads nicely into the next question, which I'm going to combine with the third in the interest of time. Because, we think about, Zarita mentioned the macro and the micro. Helen mentioned, how do we make this relevant, right? Because sometimes there's that disconnect between policy and practice. So how can these two be connected at these various levels? And also, Helen had suggested, something comparable to an Ask Me 3. Linda mentioned the hospitality training that makes it a little bit more real, is my sense, right? Because we are asking individuals to do something that is right now perceived as an in addition to, as opposed to it being woven into the practice, yes? And so Michael has presented us with dualism. And so what kind of systems changes do you think are needed, and who's going to need to be involved to make it happen?
I don't know. Can I be? I'm just thinking about medical school. I have a daughter going to pre-med, and her anxiety about not getting into medical school. And so what I'm thinking is that we need to start from the creation of the profession and who is accepted in the profession. Is that right? So when I became a clinician in the 1980s, and I was a therapist for many of the borderline at the time were women patients. One of the models that helped me a lot and hopefully helped the patients is to think of a patient with a heart, with a gut and legs and a head. And how can the patient integrate the heart, the gut? So if they react impulsively, it was the gut. They were using the gut. If they react only their heart, they were falling in love. We know they're going to fall out of love. If they're using the head, they rationalize things, and then the suicidal behaviors will happen. And the same thing, not that I'm saying clinicians are borderline personality disorder, but to kind of explain, I'm not insulting the profession, but to kind of think about how we accept, who do we accept? Are we accepting someone who has a heart, who has a mind, who has a gut, and knows how to work with all these pieces? And if they don't, what are we doing through our training, social work, mental health, clinicians, healthcare? How can we begin to implant that this is expected as science and knowledge of science is expected? Are we integrating all these pieces from the beginning?
Maybe just to take off from that is another thing that's kind of been implied but not explicitly said is that we need to just massively diversify the mental health workforce and massively integrate that with the rest of our workforce. This is not really, part of overcoming the dualism is actually the integration. So we've seen several people presented. I think Jessica presented a slide where the patient's in the middle, right? And it made me very happy. And there's several things about this that do make sense, I think, to point out. One is that the field of psychiatry has evolved quite a lot, and many psychiatrists are really psychopharmacologists. They are actually not in it to be in talk therapy and treatment through words, and there are other people who actually that's their goal and mission and skill. And I'm a primary care doctor. I actually have more time to talk with my patients than the psychiatrist does. Just in terms of how the panels work, I actually have more minutes in my session for talking with people, and the psychiatrist is basically just changing the meds. We have many places are experimenting or just elaborating integrated care models. There's different language for this, and some people use the language of collaborative care, which I think Jessica used. Other people use integrated medical behavioral health models. That's like the language they use. In the end, you have to actually figure out what are they talking about? Like, what does that model actually look like? So we actually have social workers in primary care, psychiatrists in primary care. Mostly the social workers are started with training in substance abuse disorders because SUD was a huge phenomenon at Boston Medical Center. This is like a major issue for us. But of course, dual diagnosis is also a major issue for us. And so all the social workers who were starting with substance abuse, as that model expanded, now also, most mental health is treated in primary care, right? We talk about it as if it's psychiatry. Most psychiatry is in primary care. Most SSRIs are given by primary care doctors, not by psychiatrists. And to go farther, a lot more and more of atypicals are also being given primary care. So like the model is breaking down all over the place. And that will require support and structure and lots of diverse personnel.
So places where we can integrate some of these models would be, and systems that would be changing would be through the Clinical and Translational Science Awards. So 62 institutions around the country have one of these awards from the National Institutes of Health. And they have been able to transform the culture at these institutions, especially for community engagement. So this is one place that we could also have health literacy training through the CTSAs around the country. And I think this would also provide funding as well as infrastructure. Some other places that were not mentioned would be the emergency departments. These are places where these are first responders, just like the people who are first responders through the clinic. Community town hall meetings, I think, are really important areas for us to be involved with as well. And then teachers, they are also people who see people with mental illness right from the start when they're early. And they don't know the language to use, and they don't know they're not health literate as much as we would think that they should be. So they would also be people that we would want to train up. In terms of physicians, when they were talking about cognitive impairment, we wanted to jump out of our seats in the audience because we're not allowed to speak. But 33% of people who have Alzheimer's disease don't know that they have Alzheimer's disease. And when you include the caregiver in that estimate, it's 45%. That means there's a lot of people there where the physician knows the person has Alzheimer's, but they haven't told the patient. So we're out there doing screening with community health workers using the MoCA, the Montreal Cognitive Assessment Scale. And we're able to then add those people to the workforce to get people early screened. But then when they're screened, what happens? Physicians don't feel comfortable talking to the patients and their families about their dementia. So I think these are systems that have to be considered. Community health workers, they have a lot to offer. And bioinformaticians, as Dr. Park was talking about, these are suggested techniques for machine learning, deep machine learning. And then library scientists, they're also really important for us in what we do in our work as well.
Speak. Thank you. I think a skill that people need, both recipients of care and the caregivers and everyone else involved, is the ability to problem solve when the unplanned happens. I think the gentleman who was the EMT did a wonderful job about that. He saw those medications and then he put it into a pill box, and the woman couldn't read the pill box, so he changed the icons on it. I think we will always be faced with situations that aren't what we learned in school. I certainly saw that in my clinical practice. And I would hope that our structures and those who people report to can somehow give them the wiggle room, the capacity to try something, try the untried. And how do we give that permission? And that's an organizational change I would like to see happen. And that comes from the top leadership down. And some people in this room represent that top leadership. And how can you give people the latitude to try their best and come up with a tailored solution in that way, and to reward it in ways, even if it's just saying, great job, you tried something, you did it well, or let's try this way. So I think that it goes from the leadership down to the worker bees, to the family, and everybody else, including the patients, the people, and the recipients. Let's teach some problem-solving skills, because nothing's going to happen just like the textbook, or it doesn't happen that way very often.
Well, there's just so many parts of this puzzle. It's astonishing, for example, that in many places the criminal justice system is actually like an extension of the public mental health system, except that's a really cruel way of doing it. Probably not successful in a lot of ways. We have a system at Boston Medical Center called the BEST program. It's actually a regional response program, so we actually can send mental health workers out to the home in a 911 call, so that actually the first point of contact is actually a mental health worker, not a uniformed officer. It changes a lot of what may happen in that scenario. There's just a lot of room for improvement in some of these things, and just the capacity to send a mental health worker to the home is fantastic. And a lot of places, really the first choice you have, or the only choice you may have, is to send a uniformed officer to the home, and you just don't have a lot of control of what's going to happen there. Of course, there's a lot of room for improvement in that, and then the provision, the access to mental health services in facilities is just really highly variable and often insufficient. So another thing just to say is this is actually a topic where there is a fair amount of evidence, in terms of models that work. Warm handoffs, probably not enough. Several papers now showing warm handoffs, probably not enough in primary care. But collaborative care, I'm looking at review articles with like 35 articles all successful, like collaborative care models. Now you have to look at what does exactly that mean. Or integrated mental health, behavioral health models, like review articles about this all saying like this is the way to go, why don't we do this? So the question I think is not, is there evidence here? The question is, why have we not changed systems to do this stuff?
Thank you, Michael. And then again, the questions presented had been, what kind of system changes do we need, and what kind of resources do you think it's going to take? And I heard responses like lots of diverse personnel. Okay, so we have to maybe consider what is the definition of diversity when you say diverse personnel, right? Let's think about that. And then also we heard about the CTSAs and the HL training and having to think on your feet, because a lot of situations when we're dealing with individuals, it's not all textbook. We can put, for example, wearing my interpreter hat, we can put interpreters through 120 hours of interpreter training before they're even on a unit. And guess what? Something's going to happen that was not covered in any way, shape, or form during those 120 hours, right? So this is the reality of what we're doing and in our environment. The other thing that I continue to hear is, and I borrow this from a colleague, is how can we, what do we need to do, or why isn't it happening regarding leaning into the discomfort? Because once we are able to address some of this, what can happen? Michael just, spoke about a lot of, evidence-based and journal articles, and that's all fabulous. However, we all know of or have an awareness of individuals who are struggling. We see the top 10% of the iceberg. We don't see what's going on at the bottom. And we see individuals during that moment in their day, right, as opposed to what their entire day is like. So in order to move forward, what kind of resources do you think it will take to move forward? The world is your oyster. What do we think, what resources?
So I'll just start with some very specific resources that I live with all the time, and that is through the funding agencies. So I'll talk about those. The NIH, I know Dr. Compton said NIDA, doesn't fund those things, but he actually didn't know if they did. And I know that they do fund some of those grants. Especially as it relates to cognitive impairment and also substance abuse, like cannabis use, or there are other very creative ways that we could get some of this funded through the National Institutes of Health, through the National Institute of Aging, through other HHS institutions. Also, the CDC, they have very clever ways also for us to find funding. And then within our states, we have the departments of health. They are very good places for us to get funding for local as well as state funding. Then the NSF, so Dr. Parks was talking about all the bioinformatics pieces. That's what NSF will fund. But they look for signals. So when we're looking at all these signals with these millions of points of data, we need all of you to really be able to decipher what it is about those signals that's really true and what's important. Medical schools, nursing schools, these are other places that we could get some funding, as well as all the other places we go for foundational work. But also, just to raise the awareness again, I think we just need to get word out. Then we have to have headlines. I looked at Medscape yesterday, and the Medscape headlines for Medscape Psychiatry, Medscape Medicine, it was about stigma and the stigma of depression. And it even said burnout is really not burnout, it's really depression among physicians. So I think these ways, when people start to see these in the headlines, they'll start to realize, oh, this is really an issue, and they'll turn their attention to it, perhaps.
I just want to clarify something, and I don't know if we can open it up to other people, but this question has to do, how do we move forward? Well, that's just moving forward. That's just moving. Where are we going? And I want that sense of what this is going to look like. Moving is just passing through and getting some money and resources. I'd be really curious to hear what people see as what the ideal would look like. So that's my question there. Maybe if I knew that, then I could help figure out how to get there. So let me turn it back to you. Where would you like us to move forward?
He just interpreted on you.
We have a battle of the mental health folks here, right? Where would I like this to be going? Certainly in a much more humane way, a less segmented way, and in health literacy. And I know we talked about health literacy as communication, but health literacy is really about the other person knowing about, considering what they need to do and the fact that they can do it or are willing to do it and want to do it. Really looking at what the other person will know, do, and feel. And I think that's what we need to consider. But what that would really look like in a system, particularly in our contemporary broken U.S. healthcare system, I don't know. And that's hard for me to answer. I'd be curious what other people really have to say about that.
Okay. My push will be to work with medical interpreters. You already have medical interpreters, and we understand that not all of them are qualified and are trained, but they can give you an history of what they observe in the medical field. In 1980s, when I started working at Cambridge Health Alliance, it was the second program in the country that I started. Dr. Stokel at M.S.W was the big influence in primary care, and so I had a bunch of physicians that allied with me in terms of providing services to the community in Cambridge that was going to Mass General. So they were driving far away from their community because Cambridge at the time was not a welcome place, which has changed completely in the last 30 years. And so work with the interpreters. Don't use interpreters. Make them part of your clinical team. Understand what's going on with the patients, the cultural pieces, and also with there's information. We're not supposed to be talking to patients after the session is over, but as you take the elevator, you hear things. You sense things. You see a family that has been abusive to a patient. These are all information that kind of gets lost in translation because there's not a place to come afterwards. And so create a team where interpreters are part of that clinical team and they're not just a nonsense. And I think that our system is afraid of having people who are from different cultures and different backgrounds with different accents as being seen as professional. And I think that's the elephant. I think we have racism like we have in any country, but I think we still have racism and we can see how politics are turning now. So we understand that there's an elephant in the room. And the elephant is that we maybe are not comfortable with professionals who do not speak like us and look like us. And so we're going to have to change that because the population does not look maybe like most of our clinicians, although it's changing, yeah.
So, there are a lot of research questions that are relevant here, but I just want to split my comments into, there's research questions about how to do teams. Like team science is like a field, but there's like a lot of room for improvement there, and how to spread that, And so there are people. Another element of the kind of iatrocentric phenomenon is that even when you get a lot of teams together, people kind of just defer to the doctor, who actually may have spent the least time of anybody in that group with this patient, and may have the least information relevant to whatever is being considered at the time. So, developments in team science, developments in implementation sciences, without pointing at anyone or without any blame or anything, of course, we want a robust AHRQ. Like, that's the seat of this work. That's the institution that should be supporting and funding this kind of science development. And, a healthy, robust, well-funded AHRQ would be a way to move this needle forward. Now, as it is, now to the second part of this, even with that, we need funding models that make sense for this. So actually, population management can support this. If we're building this concept of a medical home, but that home, can we pay the mortgage on the medical home? If we can't pay the mortgage on the medical home, forget about it. But if we're going to build that concept, then that would include actually a diverse workforce, including people who are not physicians, who are trained to talk to people, and that the training actually would support that. I know, Lila, you're going to tell me not to use the word mental? Oh. All right. So anyway, but like maybe the medical home can do that, but only if people talk to each other. So there's oftentimes the person who has touched this patient the most has the smallest impact, has the smallest footprint in the EMR, and the doctors don't even read the physical therapist's notes, and the social worker doesn't even, it's just an astonishing thing. It's almost like you can see that there's different cultures communicating just in their own strata, and then the capacity to look across those strata and say, can I see this person here? And how does that person emerge into so what's the goal? The goal is to decrease human suffering, to improve function, and to treat disease. That we can't do that without identifying people who need help and to find a way to support people. There's even some evidence of things that might work. We're doing depot injections in primary care, right? So there's ways, there are models that can change the basic infrastructure. If you say you can only get mental health services if you go over there, is not working for a lot of people. Services that patients will never utilize have no chance to help them.
So this is the final question. And since we're doing really well on time, we have until 4:30. Yeah. See, we're cooking with gas. We're cooking with gas. We have the opportunity to open up questions to the roundtable members on any of the questions that have been posed here. So I'm happy to go over the questions again. The final question being, what do you think are important research questions to pursue? So if folks have any thoughts about what kind of system changes you think are needed, what do you think it will take to provide the healthcare team members with basic knowledge about issues? What resources will they need? And again, who needs to be involved? And what are some research issues that we should pursue? Mm-hmm. You go ahead. Linda, I think you want to go first, so please.
I'll go. again, I'm really pragmatic. So pragmatic trials, I think, are really important. And implementation science, as we heard about, that's the old demonstration projects for those of you who lived through those. Now it's called implementation science. So things that we've heard about today, how do outcomes change based on different literacy strategies? So we have different strategies we see. Sometimes it's quasi-experimental. Sometimes it's, it's on purpose. But if we have these different strategies, we can then be able to see, are there better outcomes for those who have these different strategies? If it's an Ask 3 or an Ask 8, whatever it is that we're doing, the work that's been done through health literacy media, those are questions that are, they're data that come from those, and you can actually find out if one is better than the other. How do different techniques work? We also discussed recently in a conference that there's one question, or two questions that people should always ask, and one of those was brought up earlier. When you first come in, you get somebody 2 minutes, or you just ask them, "What can I do for you today? What exactly can I help you with?" And the other one is the magic wand question. That is, that Katina and I did a study, and we asked women, if you ran the world, what would you do to change your life? And women told us so many great things about things that we might have known, but things that we didn't know. And we did another grant based upon that. They needed transportation. They needed some structural, functional things. So those are really powerful questions that you can ask people. We talked about the formative work as well. Not all the formative work has been done, I don't think. And then we talked about integrated healthcare and looking at the differences between those that have a community health worker, the nurse, the physician. Are there specific outcomes that are better because of those compared to the systems that are just traditional systems in different settings, in urban settings, in rural settings? Where are these changes the most important? And then one of the things that one of our students just defended her dissertation on was the MCI, the MOCA, the Montreal Cognitive Assessment Scale, looking at these scales differently for white populations, black populations, Hispanic populations, and found that the thresholds for the needle is different to calling someone mild cognitively impaired or not, based on your race and based on your education. And so these are very testable hypotheses about the tool itself. Culturally sensitive tools. Maybe someone doesn't know what the rhinoceros is or the camel. These are testable hypotheses, and these are things that really get to the foundation of what we do. Is the test actually sensitive and valid? And then just one last thing, I think that would be something very cool, would be something that we've done before in another venue, which is the Sentinel Network. If you had Sentinel nodes around the country who were all working on the same similar thing, you could have 10 different sites around the country, diverse sites in urban, rural, and suburban locations, answering a testable hypothesis, answering a question, using standardized tools, and really have great opportunity to do formative research there, and also assessment, surveillance, as well as testing some hypotheses. So I think that's something that this group should definitely consider.
So I actually think that because of a lot of the funding structural changes and because of the relative weakness of some of the funding agencies that should be funding stuff in this space, actually what's happened is collaborative care and integrated mental behavioral health, it's just actually moved into the QI realm. Now that's actually maybe okay too, but health systems are all experimenting with this quite actively, many of them, and are going to come up with approaches that they can deliver and hopefully will be effective. But there still are lots of, there are a lot of formative questions left, and really, one of the reasons why I love research is because, like, it's complicated, and we get to keep our jobs because it's complicated.
The questions never go away.
And you can always, there's still more vistas, so there's still more places to make things a lot better. There's so many different topics. Just among the topics that have come up, there is no difference between, we use words like language, and then we use another word like culture. There's actually, they're deeply they're just interconnected. There's just sociolinguistics. It's actually all one thing. And when we talk about language and culture and mental health, it's actually wrapped together. And now you're going to try to do this interaction with an interpreter, and so you have this other mediated phenomenon where you actually have this other person who is functioning to transform your concept back to this other person. It's quite tricky, and there's lots of room for research in these areas. You would think, for example, that the interpreter could say back to you, instead of just telling you what the patient said, you would think the interpreter would say back to you, if I'm the clinician, I think that the patient is saying something that's nonsensical and maybe actually represents a thought disorder. They're actually not allowed to say anything like that. And there's actually no basis for that. They can try to clue in the PCP by saying something nonsensical. But oftentimes they don't, because there's also like stigma there and trying to smooth things over. There's actually lots of room for research in how to use the interpreter, how to make them part of your team. I think you're absolutely right. They should be part of a team. Most doctors relate to the interpreter like a tool. Like they have a tool belt, and then they have this tool, they have a stethoscope, which
And that's
really
our
is
first
meaningless.
name.
And
Interpreter.
and then there's an interpreter that's you think the stethoscope's meaningful? We'll talk later.
It's a great visual of what the meaning.
Yeah, exactly. Touch the Kleenex box more than the stethoscope, and then you're helping patients.
We also have to be careful because interpreters are also human beings, and they also have biases, and they also have biases about mental health, and also there's the political barriers. So we have a tendency in our society to hire people that reminds of us, and so these are people who had power in their countries, that are assertive, that can do well in exams, but they also were the oppressors of the people we're interpreting for. So it's not that the interpreters is the only solution, but we also need to understand that interpreters are also bring with them many, many different dimensions, and that it has to be all done with care and love and training, and it has to be a mutual relationship. But yes, interpreters can at times help you, and they can also do some harm. So when we train interpreters, we always say, would you have killed the patient or not? And literally, we have the power to misinterpret by mistake or intentionally and real harm a patient. So we also have that power like providers have. But we do need to work together more. Yeah.
Well, just some thoughts on research, and also going back to terminology too. When we talk about behavioral health and mental health, I think of so many different conditions. Babies who are born with an intellectual difference or developmental difference, those who acquire dementia later in life and their cognitive skills go down, those who acquire it through trauma, a major thought disorder that flares up and is okay later on. So I'm a little concerned about, I don't want to do too much segmentation, but we use the term behavioral health or mental health. We're not all talking about the same thing. And my ongoing request, and Michael, you know this well, is that in all research that there always be a practical element beyond more studying. Because more studying is good, more research is good, but I speak for those people of what are we going to do today with that piece of information in my setting. So I would really hope that all research always includes a very practical component.
I want to point out a funny little thing in the nexus between mental health and health literacy in the measurement side, not for the cognitive tools, which you had mentioned, Linda, but on the health literacy side. So there are a handful of tools that purport to be mental health literacy measurement tools. And I kind of regarded them as not being actually about mental health literacy, but about mental health knowledge. And so this is like a conversation maybe to take offline, but if you'll notice, for example, that none of them are included in the health literacy tool shed. Okay, so if you go to this website and look up health literacy tool shed, there's now like 133 tools in there, but I've not included any of these mental health literacy tools because I don't know, they're not even measuring health literacy. So, but obviously that represents some kind of a disagreement. Most of these tools were developed in Australia and other places where they've been advancing this notion of mental health literacy. It's kind of like a knowledge test. So there's still room for lots of development at that nexus.
Any final comments or questions from the roundtable? Oh, all right. We have wait.
Terry was first.
Okay, Terry, and then we have Joanna, and we have Laurie.
This is a question for Michael or any of the other MDs in the room. We haven't really addressed, as people are getting older and taking more and more medicine and seeing more and more physicians, prescribers, how much of that do you think is all the medicines people are taking? How much of that do you think is driving some of the depression or anxiety or other behavioral or mental health problems? And then who is it you happen to be lucky enough to have a good primary care doc who knows every medicine you're on?
Well, you point out a very important, good area for research. There's actually a nice, strong movement developing for deprescribing. Really, to be honest, this came out of geriatrics. Geriatrics is kind of the league leader for the deprescribing agenda. I've recently been, written about that, advocated for that too. It's very difficult to know exactly how to go. If you have diabetes and high blood pressure and cholesterol and glaucoma, you're already on evidence-based treatment for 10 medications. So when we say, for the average person with those conditions. So, when we say polypharmacy, we have to be careful about what we're talking about, and there does come to be a point when the kind of the evidence for benefit is bumping into the risks for polypharmacy, and so it actually gets to be complicated. But on average, there's a lot of excess medications that people go on things for a long time, and there may be side effects that are underappreciated, like mental health side effects. So there's no question.
Just out of curiosity, how often do you think, I wonder if this is driving the depression or anxiety? Does that ever cross your mind?
Well,
I don't know. There have been a lot of suicides in my community that have just been very unsettling for people.
Yeah, it's in general. If you go to a clinician with a concern for a possible side effect, in general, on average, they will be a cheerleader for you to continue to take that medication. Because they've already made a calculation that medication is for your benefit, and it takes a relatively assertive patient to say, you know what, I'm actually not taking this medication. Take it off my list. That's actually an assertive posture that many people don't take. So there's often a huge gap between the purported list and the actual de facto list. And so we call it like non-adherence, but if the person's like, no, I'm over my dead body, and then sometimes it's actually over their dead body.
I don't think people are aware that this may be driving the depression. I don't think most people are aware that. The side effect. If you read what you get at the drugstore, it might say that, but you think, well, they just a CYA. Well,
actually, Mike mentioned a project that we're doing earlier with a phone system that reaches out to patients. It's actually for medications on the REMS medication list. So many providers don't even know, but the FDA has a list of dangerous medication called REMS. These are medications that FDA has decided that clinicians should support with augmented educational support. Many of the providers don't know which medicines are on those lists. These are medications that have a bad side effect profile such that everyone should be taught about these side effects, and yet if you go and talk to patients, people just don't know. And even if you talk to the clinicians, it's all over the place. And, most people sign away their rights to get more education when they go to the pharmacy. No pharmacy is actually set up for that. Okay, stop. My soapbox can come later.
You can talk offline when you go to dinner or whatever. We're running really, really close now. So Joanna, if it's a quick question, please.
I will turn my long question into a very quick question. So I guess when you guys sort of brought up the idea of where are we going, right? And Bernie started the morning with saying the goal of addressing social determinants of health, literacy, cultural humility, competency is to get to the triple, if not the quadruple aim, and equality for all. So I think that I haven't really heard today a lot of us talk about really macro system level things. So I think Michael talked a little bit about how our current healthcare system is an illness-based system, a fee-for-service system, a volume-based system. And there are very few national programs that go to alternative payment models or true quality models. So how do we really get the healthcare system to focus on health and wellness and not illness, and create a system that maybe caters more to what globally has been shown, that if we sort of spend less on biological health and more on social needs, that we will be a better, healthy nation. So I would love your ideas on how, as a nation, we get to those kinds of system changes.
Thank you, Joanne. Larry?
A quick question. People may not even know the answer. But Michael mentioned an example where mental health workers are the first responders. But typically, I've heard throughout the sessions and throughout the day that law enforcement are typically the first or are often the first responders. Is there any training done of law enforcement in these areas? So just curious.
Yes, but it's all over the place. It's all over the place. So you still have, death by cop happening wherever you go. So it's all over the place.
It's also in the prison system, how much are the people who are working in the prison system trained in mental health issues, because they're the ones that replace the state mental health system. So I actually have a podcast, one coming up about justice-involved individuals and the intersection with health and health literacy, and one with a policeman about what we have in common when it comes to communication. So that's what I meant. We have to reach everybody. It's way beyond those who are working in a designated clinic or hospital who have a healthcare title in their name. It's all of us these days.
Just on that note, in almost all states, the state has subcontracted out the health provision in the prison system to for-profit companies, many of which actually have severely restricted formulary and access to mental health. So in your state, you can look it up, you should actually see what those contracts are and see how they've restricted access to mental health services in the prison, where there's a ton of mental health problems.
Well, thank you so much for all your thoughts and your ideas. This has been a very stimulating discussion. I'm now going to turn the microphone back to Bernie.
Thank you, Wilma. Thank you, the panel. Thank you very, very much.